Welcome to the Byja radio show. I'm your host, Dr. Byron Jasper, and we are recording live from J. Kinba Executive Suites in Baton Rouge, Louisiana, with special production by Becnel Media. And we are back once again, and it is a special day. By the time you all hear this episode, it will have passed, but today is the amazing Founders Day of not only myself, but our stupendous, illustrious, most cold, frozen brother that I could see and possibly be next to on a microphone, Patient Zero, aka Mr. George Becnel. Now, Mr. George Becnel, before I bring you in to actually explain to the listeners who may not be aware what Founders Day is, let's just go ahead and start by saying you look very dapper in all of your amazing Founders Day regalia. I mean, you're just black and gold up and down, and people don't realize that the colors of the clinic are black and gold for a reason, one of them being the fraternity colors. But I wanted to just go ahead and give you your compliment. So welcome to the stage, Mr. George Becnel, aka Patient Zero.
Thank you so much, brother. You know, it's December 4th. When you hear it, it won't be December 4th, but it's December 4th as we're recording this. And, you know, I got to put on my black and gold on December 4th, if nothing else. So I appreciate that.
Yeah. So for the listeners out there who may not be aware, myself and Patient Zero are in the same fraternity, the amazing Alpha Phi Alpha Fraternity Incorporated, founded on December 4th, 1906. And I won't go into all of the history, but let's just say we are the first Black Greek letter organization out there, and I'm pretty proud of that. And I think, we're trailblazers. Not sure if we are the first dynamic duo to do a DPC podcast that talks about all the things that we're doing. I know there are other DPC podcasts, but I don't know if any are co-hosted like we do. But I'm happy to say that we're blazing trails not only at Byja Clinic, but at Byja Radio, just with the dynamic duo between myself and Patient Zero. So outside of that, how are you doing, brother? Let's just start with that. Just kind of get some housekeeping out the way.
Well, you know, first of all, servants of all, we shall transcend all. So, you know, I had to put that out there. We are, you know, trailblazing a new path, and I'm enjoying to be on this ride with you. It takes a true visionary to come up with this kind of things, and that's you, brother. And the seven Jews will be proud of you. So I'll say that. But other than that, man, I'm doing well, man. I can't complain, man. Life is good. I'm just starting some new beginnings. So I'm really excited, man. Life is good. Yeah. How are you?
Yeah, man, I'm doing great. I will say that I had a few people actually reach out, whether I'm getting phone calls from patients, but also getting different conversations with people that we're having just random phone calls and conversations with. And one of the things I'm hearing about is that it's actually very cold outside right now. Now, we could easily segue into why it's cold relevant to the fraternity, but the thing that brings this topic full circle is that right now, what a lot of people are often experiencing besides cold weather are things like cold symptoms. So we are going to talk today about different things that are related to the common cold and how to potentially look at that actual diagnosis and or treatment for the common cold. Now, it's not going to be as robust as we would possibly do if this was extremely medical and medical only, but we want to talk about the common cold in a way where people can learn how to access what they should do at home before they potentially decide to seek care from a medical professional. So we want to give some context on what the common cold is, because I have people who call all the time and say I have a cold and I need a prescription, and they have no idea what a cold is, and they just think basically they don't feel well, so they definitely need to be treated with something. So we'll start by just going over some basic numbers. So I'm going to kick it over to George because I normally do the stats, but I'm going to let George go ahead and tackle and give some stats that he may actually have in some notes that he has in front of him.
Okay. So the common cold, there's 1 billion cases annually in the United States. That's a lot of colds. That's a lot of cold cases.
A lot of cold symptoms. And I think for 1 billion cases, right, not the potential people, but 1 billion cases, some people can get the same cold over and over. And by them getting the same cold over and over, they would potentially have that problem where you will say, okay, well, look, I'm getting it recurrently. So what do I do about that? Again, we'll talk about that. But the idea of 1 billion cases in a year should tell you how common this is.
Right.
Now, what other stats do you have, George, if you don't mind?
I'm looking, children experience 6 to 8 colds per year, and adults experience 2 to 3.
Right.
Kids in school, learning around all them other nasty kids, and they just getting sick, spreading germs and stuff. So that's why the kids' number is inflated, I would assume.
Yeah, I think that's spot on. I think the other part of it is that their immune systems are not quite formed like an adult. So they're more prone to infections because their immune systems are still being built up. Mm-hmm. And those are the two major stats that we're going to talk about. Like, we can go into tons of numbers, but 1 billion cases and the fact that most adults have 2 to 3 common colds in a year, and children can have anywhere from 6 to 8. Mm-hmm. So what that means is you're oftentimes having problems relevant to this diagnosis and don't realize that it's something that's pretty normal. It's pretty easy to get. It's pretty easy to deal with. I actually have a good friend of ours that are potentially listening to this episode. What up, Charles? I'll say hello to you because we had a conversation, and when I was talking to Charles, he said in so many words that his whole household was sick. He's a married man who has some amazing children, and his spouse and his children were all sick, and he wasn't. And he basically reached out and said, well, how do I prevent getting sick? And one of the simple things that we'll talk about to do that was just being very hygienical of washing hands and things of that nature. But the reason why I brought that up is that he was one of the many people where I end up engaging with them, and they actually talk about cold symptoms. And the cold symptoms they will say is, I don't feel well and I'm having fill in the blank, and don't put it together that it is a common cold. So we're going to talk about some symptoms, and I'm going to start by kicking it over to the co-host to do what we normally do and just ask some questions. So George, can you give me an idea of what symptoms usually start the actual common cold conundrum, right?
Sure. Runny nose, sore throat, cough, low-grade fever. And look, I'm glad that we're talking about this, because if you type that in WebMD, it's probably going to say you're going to die.
A little death, not a full death.
Yeah, a little death, low-grade death.
You might come back. That's what they're trying to do. They're setting your expectations very low. So if you have a good outcome, you're like, look, what movie was it? The Hangover?
Yeah.
But did you die?
Right. Yeah, man, WebMD is going to tell you have terminal pneumonia.
Yeah. I love the fact that, and we talked about it on one of our earlier episodes, that a lot of people get their medical degree from WebMD and this other university called Google. Right.
Google.
So the Google University doctors often come in with the common cold symptoms that George lined out, which are runny nose, sore throat, cough, and potentially a low-grade fever. And they'll call us and say, I automatically know that either I'm on death's door and I need to get some major prescription to be treated. But before we even go into that, we on the medical side often start by going through each individual symptom to try to get to a place of, do we need to treat this with a prescription or not? And do you need to come in to see us or not? So before we go into a lot of detail on treatment and whether or not a person needs to come in, I'm going to start by asking the simple question to George to see if he can give me a good answer at what is constituted as a fever versus what's not. And I'm asking for an actual temperature for this. Now, why am I asking for a temperature? Because what happens is I get a call and the phone rings, and of course I say, hello, it's Dr. Jasper. And first thing I hear is I'm having a fever. And what do you think my first question is besides what's the temperature? Is fill in the blank. So this is the first question that all medical people will ask you. And George, I've asked you this question wholeheartedly. It's not in your notes. And I'm going to say very plainly that when you hear the question, you're going to say, yeah, I've heard that before. Now, my hope is that you've learned from this question, but I'm going to pose it to see what is the first question I ask people when they tell me they have a fever.
Well, what's your temperature?
Okay. So what do you think the follow-up question to that is, or a variation of that question? Did you take it with
Did you take it with a thermometer?
Correct.
Yeah.
Now, how many people?
Or you just took it with the back of your hand?
Yeah, my favorite.
Man, I'm burning up.
Exactly. My favorite conversation with most patients, and I'm being very, very sarcastic, is, I have a fever. Okay, well, what was your temperature? Oh, well, I don't have a thermometer. How do you know you have a fever? Well, I feel hot. Again, I don't know where in medicine that this has become a way to diagnose fever, because if you came in to a hospital and they said, well, you have a fever, and you say, well, they never took my temperature. No. You feel hot. You would look at these people and like, what kind of witchcraft are they practicing in this hospital? But some reason at home, having a thermometer is almost as foreign to people as having a dog that does tricks on command. Like, it's just one of those things, like if you got it, you're one of the few. But if you don't have it, it's almost normal. So we started to have to tell patients, you need to buy your thermometer and keep it.
Yeah, I got
it literally is not that expensive. No. And it's something that really helps us figure out, do you have an actual fever? Not I feel hot fever.
I'm about to say, I can eat some spicy ramen and feel hot.
You could feel hot for a number of reasons. Your AC might be broke. Or you're in Louisiana, and I don't know, maybe it's summertime. That could also be a reason that you feel hot. But hey, a temperature actually tells us if you have a fever. So now that we're off that soapbox, George, what is the actual degree measurement that constitute a fever? Now, it is not in your notes. I'm saying that to say, so don't fall for the trap, because I know you see the number that you're going to say, but don't do it.
I'm not going to say that number. Okay. Because I got my own number.
Okay. All right now.
So I believe you're supposed to be at 98.6.
Okay. So that is the normal temperature.
So I would say anything 98.7 and above might be constituted as a low grade fever.
Might.
You know, if it gets up to like 99, 100, you know, for the 99, 2000, then you might have a fever.
Is that the same year that Cash Money was taking over? Is what you're saying?
The same year. Same year Cash Money took over. It's the same time the fever took over.
That's when the fever took over.
I'm just saying.
All right. Well, my honest answer is, number one, that's hilarious. But number two, I want you to also realize that in medicine, rarely will you ever hear anyone who's really, really good at being medically trained say anything about a low-grade fever. Yeah. I've never written that down once. We don't really know what a low-grade fever is. I think it's something that someone came up with to sell something. And if they tell you got a low-grade fever, you need to go buy medicine, people go do it. We don't really care about low-grade. We care if you have a fever or you don't. Okay, so 98.7 is incorrect. The actual temperature for a fever for us starts at 100.4 degrees. 100.4 degrees or above. Dangerous. It's not. That's why, and now you see why we're doing this, right? Because as you just said, I got 100, I must be dying. WebMD.
Yeah.
You call me and say, well, my temperature is 99.9. I'm going to say, okay. Not a big deal, because to us, you don't have a true fever until you're 100.4. Now, you're going to read online or go somewhere and they're going to have a bunch of numbers. I'm letting you know the number is 100.4 for a good reason. And the good reason is that once it's above that, that's when we start to see things change in the body, right? And again, we're not going to get too bogged down, but the idea is that's when body organs, things like that start to really and truthfully act incorrectly when the temperature gets hot. Just think about if you're in a very hot room, you start to feel weird. Mm-hmm. Same thing. When your organs are getting overheated, they start to do weird things. So 100.4 is the temperature for a fever. Now, again, this is an actual thermometer reading. This is not you feeling the back of your hand or putting your finger in the wind and saying, well, it must be 92 outside, so I'm guessing I'm about 97. It has to be measured with the thermometer. So outside of that, what is a high fever for us, George? Now, this is in the notes.
I'm about to say a high fever.
Yep.
What it says, persistent high fever 102.
102, right? So 100.4 to 102 may not seem like a lot, but that's when we're like, okay, this is something very, very serious, because at this point, your fever went from being something that's almost hey, I have a fever, to now look at the temperature's getting higher and higher and higher. Mm-hmm. So 102 is when we start to say, okay, this is really something that we need to be concerned about. Now, the other part of it that George mentioned is it has to be persistent. Persistent meaning it's not something you had one time and then that's it. It's something that kind of lasts and doesn't go away. So all of that being said, if you're having a runny nose, sore throat, cough, an actual fever, and then the fever is lingering for long periods of time, and persistent for us is usually anywhere from 3 to 5 days of fever not necessarily going away. It just stays. Usually when you have that, that's when you're thinking, hey, I need to come in and see the doctor because something's going on and I may need to be diagnosed. However, if you're having some of these symptoms here and there, they kind of come and they go. They come and they go. A lot of times they're what we call self-limited, which means you have a cold, and a cold usually is going to take care of itself. Now, why would you say a cold is self-limited? So, George, I'm going to ask you, what do you think the reason a cold is literally taken care of by itself? Well, there's usually two types of quote-unquote colds. So one does take care of itself and one doesn't. So what would you say the cold that takes care of itself is based out of? What causes that type of cold?
What causes it?
I'll help you out. It starts with the letter V.
Viral infection?
Viral infections, 100%. This is why you are the co-host and you are patient zero, because you didn't even actually have to think about it that long. A virus is oftentimes self-limited, and self-limited in medical terms is simply saying that the virus is going to take care of itself. It won't actually go beyond a certain point. It's going to usually get really, really bad, and then it's going to kind of slowly take care of itself. Now, why is that important? On the medical side, we don't like telling you what I'm about to tell you, but this is the truth. One of the things people don't like is feeling bad, and no one ever should. But when it's a virus, we are not wanting to give you tons of medicine other than to help you treat your symptoms, because giving you medicine for a virus that's not going to do anything, the virus is going to take care of itself. It's going to make the medicine down the road ineffective.
Yeah.
And what do you think the medicine that everyone calls for when they have a viral infection that's self-limited and it's going to take care of itself, but they actually want?
I know. I called.
What you do?
I called one of the people and say, hey, bro, I need an antibiotic and a steroid.
Absolutely.
I need it now.
Absolutely.
I can't breathe.
Yeah, absolutely. And when you go to certain clinics where people are, in essence, the best way I can say it politely is lesser trained. Well, pill pushers, lesser trained, or they want to get you out the door. It's easy for them to over-medicate you. It's easy for me to give you a steroid shot, an inhaler, steroid pills, and an antibiotic because I'm shooting it with a shotgun, and more than likely I'm going to hit something. And you're going to feel better, and you're going to be like, well, that worked. When in actuality, it really didn't. Your body took care of itself. You're just getting a ton of medicine because it's easier to do that.
Yeah.
Now, this is the thing. If you had to pay for each medicine individually and there was no insurance to cover it, and you now have to start looking, as we did in our last episode, talking about how much different stuff costs, you may think differently about these shots,
Right.
these pills, these inhalers, and all the things in between, especially when it's something the body's going to take care of. But what tends to happen is people feel bad, and they don't want to feel bad for an extended period of time. So they just want to get medicated and get medicated quickly so they can, quote unquote, feel better. And that really is not the best strategy, because down the road, when I really need those medicines, they're going to be less effective. So big picture with this episode is that the common cold oftentimes is caused by a virus. And on top of it being caused by a virus, the virus is usually going to take care of itself in a short period of time. Now, a short period could be 3 days, it could be 5 days, sometimes it could be 7. And most people say, I don't want to feel sick for 7 days. I get it. We don't want you to feel sick either. But we also don't want to give you so much medicine that we overtreat.
Right.
And then when we need the medicine down the road for an actual bacterial infection that needs an antibiotic, it doesn't work because we gave you so many antibiotics for viruses that now your body doesn't really respond. So, George, I'll pause and I want to hear your thoughts on that, because I know you know most of this because we've had a conversation or two about, I don't really think you have an infection that needs an antibiotic. We do need to treat your symptoms, and let's treat 1 or 2 and do it this way and go from there and see how you feel. And I'm happy to say that plenty of times you've actually sat back and said, I'm going to listen.
Yeah.
I'm going to take your advice. I'm going to do it. And then we'll talk to you 2 or 3 days later, say how you feel. You're like, oh, I feel fine.
Yeah.
So what are your thoughts on the viral infection, common cold, based off of what we just laid out?
Well, it makes perfect sense, because I don't think I've had an antibiotic in like 2-3 years. You know, like I've been treated the symptoms and I felt fine. You know, my body has fixed itself like it should. So I appreciate that. But also, I'm gonna give you an opportunity to maybe debunk the myth. So if I have a cold, and it's not as serious where I don't want antibiotics or a steroid, watching 2 episodes of The Price is Right and drinking ginger ale and orange juice and with a little Vicks vapor rub, that didn't cure my cold either, did it?
Yeah, it usually doesn't. I'm not going to say it can't help, but will it clear it? Probably not. So the goal is to treat symptoms. We use the big term of symptomatic treatment. Now, one of the symptoms that you're treating, oftentimes you already hit on the treatment, but I don't think you may have put together what we call it. Okay, you said the first thing you do is, of course, sit on the sofa and do what?
Watch The Price is Right. Like,
Price is
nothing's like, there's no cold without staying home.
Right.
And watching, now Drew Carey, used to be Bob Barker when we was kids.
Bob Barker's way better. Let's just go ahead and do it.
It's not even close.
No disrespect, Drew.
No debate.
No, none here. None at all.
Right.
None at all.
So, yeah. And you sit down, you relax.
Okay.
You kind of give your body a break.
Okay.
You drink ginger ale, rub a little vapor rub on your chest, and you're good to go.
Well, before we get to the ginger ale, vapor rub, and anything else, the first thing you said is that you're sitting down and you're relaxing, and the word we use in medicine is called rest.
Yeah.
One of the best treatments for a common cold is sitting your fill in the blank down. Because most of us are going so fast and literally not giving ourselves what we need to refuel and replenish that we literally exhaust ourselves, and the body can't do what it does to fight off anything when you're exhausted, fatigued, or burned out. So rest is one of the biggest things that we will recommend. Now, what do you think most people say when I tell them you need to go home and rest?
They think they go take a shower and get under the covers, go to sleep, and sleep all day.
You believe that, or you think that's what they think?
I think that's what they think.
Okay, all right. I just wanted to make sure, because most of the patients that I talk to when I tell them you need to rest, they look at me like, well, I don't have time to rest.
Right.
And it's like, well, either you're going to rest based on me recommending it, or your body's going to sit you down. And one of the other, depending on if you're at Google or WebMD, is going to sit you down a lot differently than what we're trying to tell you to do.
Right.
So what we're trying to do is tell you rest is a good thing, especially when you're starting to feel ill. If you're feeling ill and you sit down, you may be able to get by without having 4 or 5 days of feeling sick, because you listen to your body, listen to your immune system telling you, look, we're needing something. One of them is rest. Give us that. So that's one of the biggest things that people need. It's rest. The second thing you said was drinking ginger ale. Now, I'm not going to go into why ginger ale versus this versus that, but one of the big concepts is drinking things when you're sick helps with one specific thing that we often are lacking. And I'm going to give it to you in I'm going to roll it to you in the kickball sense down the middle. What is the main thing that we're fighting when we tell you to drink all of the stuff when you're sick? Dehydration. Okay. So why are we telling you to drink stuff to fight dehydration? What do you think the reason behind that is, other than, hey, I got to deal with ginger ale and I think ginger ale is great, which is not true at all. But
ginger ale is terrible. It's terrible.
Is it all ginger ale or certain ginger ale?
There's no delicious ginger ale on earth. I don't even know why they make that. Like, I just don't get it. And some people love it. Like, oh, I'll just have a ginger ale. Like, why? I don't know.
You don't like ginger, is what you're saying?
I like ginger snaps. I just don't need ginger soda. Like, I just don't get it.
So what's your favorite ginger snacks at this point? Because you said ginger snaps.
No, ginger snaps.
Okay.
That might be it. That might be.
I thought you was gonna go gingerbread since it's December. That's
what
yeah.
Well, if I find me a gluten-free gingerbread, that's cool.
That's possible, but not really.
But like, that's it, man.
That's it. I get you.
I just don't need ginger soda.
I get you. And
ginger beer is actually better than
the soda.
The soda, because it's like in stuff. You make a mule. I guess.
Yeah, absolutely.
But
I agree.
Just to drink ginger ale for no reason,
not your thing. It's meant to be mixed with stuff, is what I'm hearing.
It's got to be. Like,
I got you.
Like, why would you just sit there and drink that?
I'm not sure.
I mean, you can grab a Sprite. They didn't have Sprite?
Yeah. Hey, maybe they didn't have Sprite when certain people were either growing up or where they were in certain parts of the country or the globe. But at the end of the day, your point of fighting dehydration has a specific focus. What is that focus?
Well, I guess when you're hydrated, it helps regulate the temperature in your body.
That's one. Now, the opposite end is when you're having a fever, what do you think starts to happen? Think about if you're in the kitchen, what happens with water in a pot if it gets hot?
Oh, it evaporates.
So basically, when you're having a fever, your body's starting to burn a lot of the fluid in one way or another. And so you're going to
You need more.
You need more. You need to replenish, right? So guess what rest makes you do when you often sit still? You end up drinking more fluid compared to while I'm on go mode and I really just don't have time to stop and grab something and sit down and have a drink. So hydration is huge. Mm-hmm. Rest is huge. And there's one more thing that we often tell you besides rest and hydrate that we always talk about. Now, don't overthink it. We just talked about it. So what is the temperature? What is the thing that we are trying to fight? We're trying to fight a fever. So what do you think the third thing that we usually tell people when you're having a cold to fight off the symptoms that we're talking about? So rest is one. staying
cool.
hydrated, and trying to basically combat a fever, right? So trying to remain cool or taking medication to keep your temperature from getting overly high, right? Because as we mentioned, when you get to these high temperatures, your body starts to basically go into something's wrong, right? Something's breaking down. We need to basically calm this down. So there's two medicines that we tend to tell people that they can take to treat fever.
Quick question before you get to the two medicines.
All right, what we got?
Wouldn't it not be better to grab an ice pack?
It's possible. It's a possible. I see what you did there. I see what you did.
December
To remain ice cold.
Yeah,
is what I'm getting at.
December 4th.
I got you.
But seriously, wouldn't that help?
It could.
Or over like taking more medicine?
Well, I would say it could. It depends on how bad your fever is, right? Now, if you're at 98.7, and you're it's a low grade, again, for us, we're not going to tell you need to go pound tons of medicine when you don't really have a fever. But if you're getting a 101, 102, 103, you can try to basically be in an ice bath and all that. But again, it's going to be pretty hard to maintain. So you need something that's going to possibly get into the system to calm these things down.
Gotcha.
Okay. So what are those two meds? And I'm sure you know them. One is very simple. You hear it all the time. The other one is not as common, but it definitely helps.
So without looking, I would say Tylenol.
That's
or what's the code name? I guess the generic name for Tylenol. What's that?
You want me to say it, or
yeah,
you
say it?
Okay, because you look like you were about to give it a shot.
I know what it is,
Okay.
but like I can read it. like I know when I see it.
Yeah.
But I don't know if I can say it.
Well, I'm gonna give you the little hack that I always learned, especially in med school, when it comes to pronouncing medical or medication names. You just literally sound it out, and eventually it starts to make more sense. So the actual medical generic term for Tylenol, generic, is acetaminophen.
Acetaminophen.
All right.
And
if you read it, and literally it's written down, it literally is spelled exactly how it is. It's just getting the flow when you say it.
Yep.
So acetaminophen is literally Tylenol. That's all it is, right?
That.
Tylenol is the brand name because at one point it was Tylenol, and then Tylenol lost the patent. Like most medicines, it went generic. And most people, when you go to the actual pharmacy, you can buy the brand name or you can buy acetaminophen. It's generic. They both work the same.
I don't buy Tylenol. I buy Equate or Kirkland's.
Yeah. And what is the name on it? It doesn't say Tylenol. It says acetaminophen, right?
And I'm good with that.
Yeah. So
it's just like ibuprofen.
Yep.
I'm buying Kirkland's, Equate.
Yeah.
Oh, you know what? My new favorite?
Yep.
Amazon.
Yeah. 100%.
I can get me a bottle of 200-300 Amazon.
Yeah. There are plenty of ways.
For like $5.
Yeah. And there are plenty of ways to get medicine for extremely cheap, both within the clinic and outside. And that's one of those that you probably should just keep it as long as it's not, expired. That's something you should keep because you're going to use it for a lot of stuff. And it's really good as a anti-fever medicine, right? It does help with some pain, but it's definitely good as an anti-fever medicine. And that's our go-to to help you break your fever. So you're in the 102s, 101s, you're starting to feel really ill. Take the actual acetaminophen, help to get the fever under control. There's one more you can also use to alternate with acetaminophen that we recommend. And this one is not in your notes, but I want you to think. We usually say take a fill in the blank, first one usually Tylenol, or a fill in the blank to help with headaches and fever.
Aspirin.
No.
It's not.
Now, if you were in the 1950s, 60s, it would have been aspirin because aspirin was the first one in the actual family. Aspirin, of course, is...
So...
Go ahead.
It would not ibuprofen?
It is ibuprofen. So ibuprofen is actually a newer version of aspirin, right?
Gotcha.
Yep. So the old version of actual anti-inflammatory medication.
You threw me a curveball
There you go.
because I just mentioned ibuprofen.
Yeah, absolutely. You 100% had it right. So this is the thing. Anti-inflammatories fall into a category that we call NSAIDs. N, the letter N, SAID, NSAID. So that stands for non-steroidal anti-inflammatory drug for the most part. So at NSAID, the class, aspirin is the first. Aspirin's the old school anti-inflammatory. And then, of course, medicine always advances. So medicine literally changed to where ibuprofen now is the, for lack of a better term, newer version. Aspirin still has some headache properties that it will help to treat a headache. It also has some properties to help with fever, but it's not as good as the newer stuff like your ibuprofens and your Aleve and things of that nature. So all that being said, we usually tell people rest, hydrate, and keep your fever under control with a acetaminophen or an ibuprofen, or you'll hear say a Tylenol or a Motrin, because those are usually the names people know. And the Tylenol is a brand Motrin is a brand. And those two are basically medicines that help to keep fever under control while you're resting and hydrating. And guess what usually happens in those instances? Your cold goes away. It literally gets better on its own. Now, you may say, well, what about my runny nose? What about my cough? What about my sore throat? All of those things can be treated individually, but none of them usually warrant an actual antibiotic. Rarely do they warrant a steroid. And then outside of that, they don't require a combination of them. So all of that being said, there are treatments for runny nose. There are treatments for sore throat. There are treatments for cough. And again, we could go down each one and talk about medicines you can use. But the common thing is for the cold is getting rest, is hydrating, keeping the fever under control. And usually the virus is going to take care of itself. It's going to eradicate itself. And once the virus is gone, you start to feel better. Now, oftentimes you're going to feel a lot worse before you feel better. Meaning if you call me and it's day 1 or 2, and then I tell you, unfortunately, look, you're going to feel worse before you feel better. It's not an actual need for all the meds that you're going to possibly want. If we just treat your symptoms, keep you hydrated, get you some rest, keep your fever under control, you're going to feel better. Most people don't like hearing that, but that's the truth. That's what we're trained to do. That's what we should do. That's how we keep you from literally over-treating and over-medicating. But most people don't want to do that. So they literally go to urgent care, or they go to places where people are going to just medicate you because it makes you, quote unquote, feel better faster. You really and truthfully are getting overtreated. So when I need to use those medicines, they don't work. And then all of a sudden you come to me after you've been overtreated for years and years and years, and you're wondering why I'm telling you, well, look, we've tried 2 or 3 antibiotics. None of them are working. Now we got to send you to the hospital because the WebMD thing that you were fearing is now true. So if we avoid and save those big antibiotics, big steroids for big things, they work better. And that's kind of the common cold wrapped up in a nutshell. So George, tell me your thoughts. Does that make sense for you if you say, look, I'm a listener, I'm hearing this episode, I'm trying to understand whether or not I feel these symptoms and I need to go run in and go to urgent care, emergency room and get all of these treatments, or I'm trying to navigate this at home to avoid going there getting this crazy bill? Does this sound like something that's easy to do and things you can do at home? Or does it sound like, no, look, I just need to keep going and doing what I'm doing?
I mean, it sounds very easy. But for me, I just call you. I mean,
when in doubt.
Right.
When in doubt.
Right. I don't worry about this.
Yeah.
You know, like as soon as something happens, I'm like, hey, bro, what's up?
Yeah.
You know, like, hey man, my nose running, man, fix it. You know, like literally, I don't worry about this.
It takes me back to one of our earlier episodes and a story that I know you remember. You called me and you're driving up I-10 and you're heading to New Orleans. And you called me and you said very much what we just talked about. You're having symptoms, right? I don't know if you remember some of the symptoms you're having. Okay, do you want to share with some of the people?
I think I was exhausted.
Yep.
I had a headache, maybe.
Yep.
I just wasn't really functioning.
And the other thing you told me is you also felt like you were starting to get a sore throat. You were
yeah.
Because you wanted to know what medicine you needed.
Yeah, I'm thinking, all right, well, doc, just tell me to go pick up this prescription at a Walgreens down there in Metairie or something.
Yep.
You know, that was not the answer I got.
And do you want to share with our faithful listeners who, if you're listening, and we're in season 2 now, if you're listening since season 1, you already know this story. But if this is your first episode, this should be a very good tale of how we do medicine here at Byja Clinic. But George, tell the people what my response and, well, not my response. What was my first question to you before we talked about treatment?
Did you eat?
When's the last time you ate something?
Did you eat?
Yep. And then my second question was, when did you sleep last? And it was those 2 questions that literally got us into, so you don't need any medicine. You need to go get some rest and eat something. And we'll start with that and see how you feel.
I think I was in the middle of a convention.
Yes, you were definitely going to something that was either educational or business or both. And you were just going. I remember that conversation.
I was working. I was in the middle of a convention. I had been working the whole time, and I was going to school. At that time, I was going like 3 nights a week.
Yes.
So I had been sleeping maybe an average of about 3 or 4 hours a night for like the last week and a half at that point.
Yep. And at that point is when George realized he wasn't superhuman and we needed to actually take the cape off for a moment and get some rest. So moral of the story is we're not just saying, hey, you need to do this in your area with whoever you're getting treatment with, and it magically just works because we said so on the podcast, and then from us talking, you just magically believe it. No, we really do this over here, right? We're really trying to get people to understand that better health doesn't just happen. You have to actually be engaged and do it regularly. And if you're doing that all the time consistently, you'll start to see better health benefits. But if you're doing the piecemeal, give me a ton of medicines and I'm just going to keep pushing, well, again, you may get by a couple of times, but eventually those medicines stop working and you end up having more problems down the road than you previously thought you would have had. And it's all a surprise. So we're trying to avoid that from happening. So outside of that, I think the big thing we're going to get with this portion of the actual episode is that people, if you're having cold symptoms, you don't have to necessarily go straight to an actual urgent care or emergency room and get treatment. If you're engaged in the right primary care setup, that person knows you well enough. They can ask you those important questions like, what is your temperature? Did you take it with a thermometer? When's the last time you ate something? When's the last time you slept? Have you tried these other things before we start with big treatments? Rather than come in, here's a prescription, here's a shot, go home and come back and see me when you quote unquote feel better, all to say, hey, it would have got better on its own. So we're trying to make sure people hear that, internalize it, especially considering this episode is out during the, for lack of a better term, cold and flu season. And the cold part of the cold and flu season is often self-limited. And if you can take care of it at home because you feel confident in what we're telling you and you're able to do those things, then do that. If you cannot, get in primary care with someone who really knows what they're doing. You really trust and value their opinion and you're going to listen. And when you do that, it will help you feel much better about the decision making that you are doing. So I think that's a good potential segue into something simple. And I'm going to ask George to kind of give people a little bit of insight on this. In terms of the primary care model that we do here at the clinic, do you think that's a good setup for what we're talking about, George, or do you think that's something that's going to be difficult for people to get access to? Because again, we got a lot of people who are busy, they're moving and shaking, they may not be able to come in for visits, but they need to talk to somebody to see if this warrants me coming in. Now, you can go to the traditional model, and with the traditional model, if you're having cold symptoms, how does a person engage? If you don't mind, George, what do you think that would be the first thing that they would do? They were starting out with the sore throat, the runny nose, the coughing, and the potential fever. And then they're trying to engage in the traditional model. So what do you think they're going to experience?
So in the traditional model, when I was in the traditional model, I would do one of two things.
Okay.
At one point in time, I had a really good relationship with my nurse.
Okay.
So I would just call, ask for the nurse, and she would just give me some advice or be able to fit me in or whatever. And when I lost that, I didn't have access to that. I would probably go to urgent care. Yeah. Because when you know, in the traditional model, you can't really ask a question. Telehealth is a thing now, right? So there's only so much that you can get answered without having an official visit because they want to charge you for a visit.
Yes.
Right. So I would say you're probably going to end up in urgent care and you're going to pay an arm and a leg for a runny nose and a scratchy throat, which doesn't seem worth it to me.
Okay. Now, can you contrast that with direct primary care? What would be that experience if you say, okay, in a direct primary care practice, I got my runny nose, I got my sore throat, and I got that potential fever. And then from there, I'm going to try to engage to see what I need to do. So what would be that experience?
Well, it's a lot different because I can text the clinic. I don't even have to call the clinic. Because honestly, if I got a runny nose and I got a sore throat, I don't want to talk anyway. So I'll just text the clinic, and then either you or Farrah is going to text me back with some type of instructions. And 9 times out of 10, there's some stuff I can just do at the crib. So I don't have to worry about it. Or I can just go run to Walgreens across the street or the Walmart, something like that, and get what I need. You know, just God forbid it's a prescription because my experience is not that great with those. But, I can, I normally have a pretty quick answer. Is very, very timely. So, I get answers very, very quickly. So it doesn't take long at all.
Well, I appreciate you giving us a good segue into potentially the next portion, and it'll be a brief portion of the episode. So you talked about prescriptions, and one of the things that we talked about briefly with prescriptions is making sure you know when a prescription is needed versus when it's not. So the second part of our actual episode today is going to be on a topic that some people are aware of, especially if you're older and you take a lot of medicines. Some people have never heard the term, but we see it all the time. It's a topic called polypharmacy. So polypharmacy, in so many words, is when a patient is taking a lot of medications all at the same time. And a lot of times when they have those medications being taken simultaneously, they start to have issues with medicines interacting with one another. So sometimes you can get a lot of medications, and if you don't understand that those medications aren't meant to be paired with one another, you oftentimes will overtreat and cause more harm with the medicines you're using to treat than it would be for you literally not doing anything at all. So in that polypharmacy space, what we're trying to do is eliminate people from having side effects or drug-to-drug interactions that will cause problems that oftentimes may make you think the disease is not getting better that you're treating, or that something's not working, when in actuality, it's working exactly like you thought it would. So, George, I'm going to throw it to you and see if there are any drug-to-drug interactions that may have stood out to you, because we just talked about two medicines that are in the same class. One is the older version, one's the newer version. So what are those two medicines, and what do you think interactions are between those two if you're taking them together?
So, I do know ibuprofen and aspirin, they don't mix. Okay. And ibuprofen will reduce the effectiveness of aspirin.
Yes.
So it won't protect the heart. Like a lot of people, like I'm one, I admit it. I'm one person who I'll take like a baby aspirin every day. But if I got a backache and I take like 4 Advil, I might not get my benefit of my baby aspirin that day because, they don't mix. Now, sometimes you just got to make a decision. Like, am I really worried about this baby aspirin this day, or am I worried about this herniated disc in my neck? Sometimes you got to make a decision. But at the end of the day, like, you need to be aware of these things because, like, somebody like me, I don't like to be in pain. I don't like to be sick. I don't like to be uncomfortable. And if I can help it, I'm gonna just go knock it out. Like, I believe in killing a mosquito with a bullet. So I'll just go take some stuff. And long story short, that's caused some issues.
Right.
You know what I mean? So now I have to be more aware and more mindful of what these drugs do and what not to mix. Yeah. Because you can create worse problems than you actually have. And sometimes you just need to make a decision like, what's worse? Right. You know what I mean? And you might have to deal with some stuff for your long-term health.
Yeah, and I think you're touching on a part that a lot of people need to hear, because some people are aware of certain things, but they don't realize the magnitude of those things. So as you just mentioned, look, if I take aspirin and ibuprofen together, it may not do a lot. True, it may not. But if you're doing this excessively and continuing to do it, not only could it cause a lack of benefit on the aspirin side, it also can cause a compound bad effect on two things in the body. And this is just one example. So too much ibuprofen or too much aspirin, especially putting them together, can cause problems with kidney damage.
Yep.
And it also can cause problems.
Especially if you're not drinking enough water.
Right. Especially if you're not drinking enough water. And the other thing is it can also cause issues with gastrointestinal problems, specifically an ulcer. So a person can take too much of one or the other, and it can cause problems all of a sudden that now you're in the hospital because you're having kidney failure and a gastrointestinal emergency that needs surgery because you took too much.
I don't care what it is. Give me the pain over stomach problems. Any day. I don't care. But look, I'm going to tell you a story, man. I don't think you know this. About 2012, I was having some shoulder pain. I got diagnosed with a herniated disc in my neck, right? And no pain pill they would give me was enough before I started going to therapy. Like muscle relaxers, all this didn't work. Yeah. So they went straight to hydrocodone. So I'm like, ooh, this is great. Hydrocodone, man. I can take this. I can go to work. I can just do life, right? And without having pain, because that's what I wanted. But, one day I came home, I had a terrible day. So neck's hurting, took my hydrocodone, and fixed me a nice glass of Crown Royal to try to relax. I didn't know that you weren't supposed to mix pain pills with alcohol, especially like high, whatever they call it. Is it high risk pain pills? Yes. Yeah. Especially those type of pain pills with alcohol.
Controlled medications. Bro, yep.
Did I not, I was trying not to feel pain. I didn't feel anything. Like I was just there.
Existing.
Like I was just like my body was there, the TV on, I'm just here until I woke up the next morning, and then I felt normal again.
There you go.
But I'm glad that I did that at home.
Yeah.
Like I didn't know any better.
Yeah.
So I wasn't trying to be like a druggie, right? And get a high.
Yeah.
But I'm glad I did that at home because had I just taken, I could have taken this pill just to feel good and go and meet my coworkers at a bar, you know, and did the same thing.
Yeah. Yeah. And it can be life altering.
Like how could I?
Yeah.
Could I gotten home?
Yeah.
Or if I tried to get home, but maybe I would have got direct. I don't know.
Yeah.
You know what I mean?
Yeah. And it happens, right? And that's an example, right? So those are small drug to drug interactions. And in a polypharmacy state, what we're dealing with is it could be those small interactions that are now magnified 2 or 3 times because you have so many medicines putting together that this puzzle all of a sudden shifts to where you're like, well, nothing's working. And it's not that it's not working, it's that all the medicines are fighting each other, or all the medicines are working too well that they're causing damage to something. And an example of something like that, and I'll make it simple, but I'll also kind of bring it full scope. And I'm going to give a small example where we're kind of not getting to 5 medicines or more, which is kind of where you start to really get concerned, but we're going to give a very small example with 3 medicines. So if I have a patient who has high blood pressure, one of the common things that we use for high blood pressure are medicines called diuretics. And diuretics help you lower blood pressure by basically pulling fluid out of the body. So you usually go to the bathroom and you urinate a lot, right? So you're peeing all the time, getting fluid off, helps your blood pressure. Well, another medicine that a person may also take if they have diabetes and high blood pressure are the new meds, the weight loss meds that a lot of people know about. So you're talking about things like your semaglutide or your tirzepatide, which is your brand names, your Ozempics and your Mounjaros, right? So if you're taking those, one of the things that those things tend to do is help you by cutting your appetite, but it also slows down the ability for your gut to start to break food down. So it makes you feel full longer. So that will also be a benefit. So now you're eating less, so you're not gaining weight. So that's great. So we got the diuretic helping blood pressure. We got this medicine, which also helping us lose weight and keep our sugar under control. And then you also potentially have a injury because, you know, you were possibly in the gym working out, trying to get your blood pressure under control, trying to get your diabetes under control, and you have an injury. And then somebody gives you medicine for pain because, look, it's a pretty significant injury. You twist your ankle, you hurt your back or something like that. So we give you something for pain. And we give you something that hopefully helps because the ibuprofen you were taking is not strong enough. The things over the counter are not strong enough. So now we have 3 medicines we're taking. And that's just 3, right? But we're going with those 3. So what is the common thing you think we're going to experience with those 3 medicines altogether? And George, this is literally on the spot. It is not in your notes. This is a real life example that happens all the time, especially when patients come to us. And I often will read their list. And one of the questions I ask them is, are you having this? So what do you think the common complaint would be with that combination? Diuretic, medicine that helps with weight loss and diabetes, and then something for pain for that injury. What do you think one of the biggest complaints we get, or one of the things I'll basically find out?
I don't know, but I would think dehydration would probably one of them.
Okay.
I think constipation probably would be another one.
And that's spot on, right? And I'll bring it back to your comment from last actual episode, right? Oh. It happens all the time. We have people come in, and that is a polypharmacy example, right? I
know what not to do. Like I'm telling you, I would rather be in pain than like be constipated. Yeah. So I know how not to be constipated.
Correct.
Like I will put Miralax in my coffee.
Yep.
You know, like I told me that. I said that last week. I just will not do it. Yeah. So yeah. So,
but you can see.
I'm aware of it, is what I'm saying.
Yeah, but you can see how quickly you are aware, because I'm sure we've either had the conversation or you are literally saying,
I found out the hard way. I have to run after found out.
There's a way you found out, right? But what do you think happens to people? They will literally say, well, look, I don't understand why am I having trouble going to the bathroom, so let me add more medicine. And then you take the wrong medicine. So now you have 4 medicines.
You just drink more water.
Well, you're taking medicine to treat the problems caused by your medicine.
Right. No, you're just taking more medicine.
So you're taking more medicine.
It's like a bad circle.
It's a very bad cycle. So that's how polypharmacy works. And that is a quick example of how quickly it happens. And when you're getting into the situation where the common cold is involved, it can happen in the exact same way. You're taking medicine to treat one problem, and then you take another medicine, you take another medicine, you're taking all of the over-the-counter stuff, and you're over-treating when your body just needs rest. It needs to be hydrated. You need stuff for fever. You need to take it easy. And your body is going to literally take care of itself. But you're putting so much medicine in, you start to cause your body problems. Mm-hmm. And then you come and say, I need more medicine to undo what all the medicine has done. So that's why we try to at least talk about polypharmacy. And this happens a lot, especially in elderly patients, right? Elderly patients end up being on so much medication that you'll often think about the grandfather, grandmother that you may or may not have with you still, and they often have these big bags of medication, and it's a bunch of medicine altogether. So one of the things that I often run into when I get new patients that are above a certain age and have a lot of medicine is I talk to them, and the first thing I say is my goal is to take you off a lot of the medicine you don't need, because I don't want you to have these interactions and that cause problems, and then we have to really work to undo the problems by giving you more medicine. So we try to really and truthfully address that in all patients, but to eliminate the ability of people coming in thinking that more medicine is always the answer. Sometimes less medicine is the answer. So not over-treating, but also not under-treating. So that is a huge part. And I'll just, again, kick it to George to just get his scenario, or synopsis, I should say, on how that may or may not seem, because I'm sure he has elderly relatives or or friends or colleagues he's seen that may be taking a lot of medicine and may be dealing with that, but not really sure how to address it. And you just said it, George. You said, look, it's a cycle that kind of feeds itself. How do you think people should, in essence, come to this cycle and say, you know what, maybe I do need to take a look at this medication and figure out if I'm taking too much or not enough or just the right amount? Is there a way you would say, look, this is how I would think this person can look and figure this out? Or is it something you just think, hey, look, you're kind of lost cause?
So I would do one or two things. I would at least look up every medicine I'm taking and understand what I can take it with and what I can't take it with. And that's where I would start. I'd also have a conversation with my doctor, because we as people, we are conditioned to feel better instantly when we have a problem. And I think that's part of the issue. You know, sometimes you have to make a decision on what is the bigger picture, right? So, yeah, sometimes you have to understand what is the bigger picture, right? Yep. So for me, I'm just fortunate enough to be a part of this Byja clinic, and in this particular direct primary care model, because I have long visits and I have an understanding of what everything does.
Yes.
Right. So I don't have to do all that research. So when something happens and all of a sudden I'm uncomfortable, I could make a real life decision like, okay, this is what's going to happen if I take this pill. Right. And can I live with that?
Yeah.
Or can I not live with that?
Yeah.
Like, is my back hurting that bad for me to be constipated?
Right.
You know, and sometimes, you know, I don't say that to be funny. Mm-hmm. That's a real life question that you need to ask yourself, you know, or if it is that bad, understand that you need to drink plenty of water, or understand you need to do X, Y, and Z. But, you know, I'm fortunate enough to be a part of this model where I have a knowledge of this, and, you know, I have support 24/7 where I can just text a number if I don't know. Yeah. So I would say the answer would be to, you know, take a look at this model if you can, enroll and be a part of one, like the Byja Clinic. If not, you know, find a medical professional that'll be able to help you. But it'll be difficult outside of the model.
Yeah, and I think the other part that a lot of people may also not be aware of is that when you have these issues, especially polypharmacy, it can be very difficult to undo some of these drug-to-drug interactions if you're on these medicines for long periods of time. And it's not saying we can't, it's just it takes a lot longer to take you off some medicines than others, right? Some medicines you can't just stop cold turkey. You could literally choose to do that, but you may feel worse by stopping it immediately or abruptly, and then all of a sudden symptoms get worse. So you have to be weaned off the medication in a certain way so the body doesn't react in a bad way and cause problems. And the other part, besides it being a very long, tedious process, is that sometimes this can be expensive. Not only is it expensive to get the medicine, but as you just heard George say, as you're literally talking to different doctor after different doctor, different specialist after different specialist, trying to figure out why you're having all these symptoms and these problems, you're racking up a bill. And you're racking up more of a bill by going back in and saying, I need a new medicine for a new symptom when the symptom is caused by the medicine. Mm-hmm. I've had patients come in, and one of the things I have a patient come in and say is, I'm an older patient. a lot of female patients specifically, and one of the common problems they will complain of is I'm having trouble with something we call incontinence. Incontinence is the best way, is a medical term, and the best way to explain it is when you're having trouble holding your urine or your bowels, right? So you're having trouble where you're losing urine and you're not doing it on purpose. So think of wetting the bed for an older person, right? So a female patient comes in with incontinence, and they'll come in and say, I need something to help me not go to the bathroom as much, right? So we give them potentially medicine to stop them from going to the bathroom and having these issues where they're losing urine. What do you think one of the common things that happens that patients don't actually have a conversation with their providers with that says, okay, well, maybe this is the reason you're having this problem? Now, we're not saying you're not having incontinence, but maybe this is contributing to it. What do you think could be?
It could be the medicine.
Okay. What medicine would you think they usually are on that may be causing it?
Probably diuretic.
Diuretic. I had literally a patient come in with the same conversation. I'm having trouble. I'm going to the bathroom too much. I can't stop going. I'm having accidents. And one of the things is they said, I need a refill on this medicine to stop me from going. And I said, well, did anyone ever tell you you're on a diuretic and that's going to make you go? And they were like, oh, no one ever really told me that. I just thought that it was a problem and they gave me more medicine. And I said, the problem is you're probably on too much medicine.
But you see, we've had that conversation to where, you know, like you say, one of these medicines cause an issue. Matter of fact, my anxiety medicine, you and I had the same conversation.
Yes.
Right? And you know, I was having some other issues and you were like, well, we don't need to give you something else. We need to change the anxiety medicine.
Correct.
You know what I mean? And I think that's important. But it's like going to, it's like, you know, when I had hair, you know, I'd go to a barber, you know, you want to go to your main barber. But when you go to a different barber, he does your line a little different, your line get pushed back. Mm-hmm. And you keep going to different barbers, your line get pushed back. You keep going to different doctors, you keep going to urgent care.
Yeah.
And you get these medicines.
Correct.
And they don't understand you, they don't understand your plan, and they don't understand what's going on. And then that contributes to, because don't think you can't be in this polypharmacy cycle just on yourself. Like you could be given that by doctors.
Correct.
You know, and just keep taking it. So you got to be with somebody who understands your medical history, understands what you're on, understands what the goal is. And that way you can have a conversation like, hey man, look, I'm feeling like this. I need something for it. You're like, no, this medicine, that's a side effect of this medicine. Yeah. Now, if this medicine is that bad or the side effect is that bad, instead of giving you something else, let's take you off this medicine and change the medicine. You know, and I think that's a more powerful conversation. However, you have to have a doctor who is consistent with you, have access to all your files, who knows you to be able to have that experience. And I think that's what a lot of people are missing.
Yeah, and I think you package that perfectly, right? I have patients on both ends of the spectrum. They want a lot of medicine. Some that want a lot of medicine and they can get overtreated. And then I have some who just anti-medicine. I don't want to take nothing. You know, I hate medicine and all that. And
like a good club of ours.
Yeah, and he's listening. We talk about it all the time. I'm sure he is, but we're not gonna call him out. But the point is, he's not the only one. The point of what I'm trying to get is on that spectrum. Our goal in our practice, and a lot of doctors out there, especially the good ones, their goal is not to give you medicine just because it sounds nice. It's to find a treatment that works for you. It may not be any medicine. If it's diet, exercise, and that works, then that works. If it's not working and you need medicine, take the medicine. If it literally can be changed down the road, I'd rather get you under control first with medicine and then take it away than let you be out of control while you're fighting and trying to avoid medicine and something bad happens. So the goal is to not have polypharmacy, but also not have no pharmacy, right? And that no pharmacy world, if necessary, can be there and helpful. But if it's not working, then you need to jump in, get some medication, get under control, work backwards. And I think overall people will feel a lot better. And people will start to really and truthfully say, well, this doctor, this clinic, this practice is different. They're not just talking. They're not just telling me I need to come in all the time. They're not just sending me prescriptions. I can't really get them on the phone. I just keep taking medicine, but I keep feeling bad. And I don't really understand why. That's not what it's supposed to be. If you're in primary care should be primary. which means that you start with us. And if we do a really good job, you don't need to do anything else. If we can't get it, then we send you elsewhere. It's not urgent care, which people think that's primary care. It's not urgent care. It should be a fill in the blank if primary care is either not available or you're just really and truthfully not sure where to start. But if you really can get into a good primary care office, your whole life changes. And the goal for us is to keep you healthy for basically the entirety of your life, not keep you healthy for 3 days, not make you feel better for a week and then tell you to come back and see us. It's to literally keep you and your family healthy so everybody wins. Because if you're a good patient of mine and we're your primary doctors, which is continuity of care, you're going to be with us for life. That's the hope. It's not a surgical thing, and nothing wrong with surgeons. I have plenty of good surgeon friends, but a lot of times those are usually smaller things. You get treated. If it goes well, you don't go back. For us, we're going to be with you for the long haul. So we're not trying to do something that makes you feel bad and keeps you coming back. We want you to hopefully get better and stay with us because we're doing a good job. So I really say that to say polypharmacy is one thing. Common cold is something different. They sometimes overlap, but overall, the big theme of this episode is that getting into care with the right people can eliminate you getting both of those things treated incorrectly and having problems in the long run. So I think we're at a point where we will go ahead and close out. And based off of that, we'll slowly but surely do a few things. So I'm going to give George an opportunity to do 2 things. One of them is going to be something you all are familiar with, which is basically a closing thought. What did he get from today's episode and things that hopefully people who are listening will take home. And then also a potential shout out because this man is approaching a momentous occasion. I want to give him the floor to absolutely celebrate himself for a second. So George, what are your closing thoughts for today's episode? And then anything that you may want to, let the people know that you may or may not be doing, I don't know, in the next week or so. So go ahead, George.
Oh, wow. Okay. That's pretty cool.
There you go.
Closing thoughts. Just again, take charge of your health. Byron, Dr. Jasper has been a tremendous resource and a tremendous blessing to me in terms of my life and my health journey. And he's the best in the business. However, when you ask who's in charge of my health, it's me. It's not Dr. Jasper, as great as he is, but he's not, right? So, when we talk about being in charge of your health, ask questions, understand what medicines do. I always want to know what medicines do. Why am I being put on this? What are my options? What are the alternatives? What can we do? So we have those conversations. So have those conversations with your medical professionals and don't just accept anything, Now, hopefully their degree is from Tulane and not Google, right? And that way you can trust what they're saying, but use them as a source of information and not just the end all be all. That's number one. And understand what these medicines do, because if you're stuck in this polypharmacy cycle or whatever this is, it's your fault. It's not the doctor's fault. It's yours. You just blindly took stuff. Ask questions. And to allude to what Dr. Jasper was talking about, I've been very blessed and very fortunate to have the opportunity to go back to school at the Southern University.
Hey.
Homa Lacumba and the Jaguars. And finished my MBA. My educational journey has been interesting over the years, to say the least. So, being able to have an opportunity to go get a master's degree, especially in the College of Business at Southern, it's a tremendous blessing. So I'm really excited about that. And if you see me in the streets, buy me a drink.
There you go. I will give him a little bit more prestige on what he's doing. So this young man will be actually graduating in a very short time. So by the time you hear this episode, depending on when you're listening, it might be dropped before the graduation, but it probably will be right around the time. So if you happen to see patient 0, definitely tell him congratulations on his journey, because getting a professional degree is not easy. And more importantly, getting a degree after you've been out of school for a little bit can be even more difficult. So kind of going back, finishing that actual journey is actually a huge huge benefit, and more importantly, it's a huge accomplishment. So proud of you, brother.
Appreciate that.
Keep it going. And definitely, if there's anything we can do to support that journey, let us know. I'll give my closing thoughts and then we'll 100% close out. So again, engage in primary care. George definitely said it. Don't just be a person who's a witness in the actual medical scene with the people you're getting care from, where you're sitting here just witnessing them telling you what to do, but actually engage in care, have a conversation, get into the actual nitty gritty of what you're taking, why you're taking it. Are there interactions? If there's a plan to be on it for a lifetime, is there a plan to be on it for a short time? And as you do this, you'll start to be a better consumer. And if you're a better consumer, believe it or not, the doctor is actually going to be a better doctor. Why? Because when I have a patient who knows what they're talking about, I'm going to be a lot more in tune to say, I want to get this right. I want to get it right, not only because I know this person is going to hold me accountable, but I also know that this person is going to challenge me to think newer, bigger, better, so they don't have the same old problem somebody had before them. So definitely do that. And if you're not doing that already, please start. If you're looking for a place that will help you do that, consider us at Byja Clinic. Again, we are taking new patients. We get calls all the time, and people always start by asking us, do we take new patients? The second question oftentimes is, do you take insurance? And we have to go through the whole spiel on why insurance may not be the best thing for you, and we want to talk about direct primary care. So if you're interested in doing that, that is completely free. We do it in person, we do it over the phone, we do it virtually. But becoming a member of a direct primary care practice is easy, it's simple, and really and truthfully, it's not really hard to do because there isn't a crazy contract associated with it. It's usually month to month. And if it's month to month and you don't like it, feel free to unenroll. If you like it, stay. And again, let's grow together. With that, we will also close out by saying we do have a Byja Blueprint book. It is available in ebook format. It's also available on multiple platforms. And this book is an introductory guide to direct primary care for patients, physicians, and business owners or employers. So if you are looking for a really short read and something simple that explains how direct primary care works and why it's really helpful and impactful, get a look at the Byja Blueprint book that we have out right now. Lastly, we ask you to support the Byja Charitable Alliance. This is our nonprofit organization where we are using the direct primary care model to help the underserved patients who may not have access to high quality primary care in the way that we do it. So patients who pay the membership in one way or another may help to benefit the lesser of the people in the sense that they don't have insurance and can engage in care, but also they may and truthfully just make donations and help the nonprofit to provide care to those patients in need. So those are the three things we're doing. And of course, follow, like, subscribe, rate, share, all that good stuff with us at Byja Radio. And if you're listening and we're on episode 17, which we did not say at the very beginning, and you have listened this far, we appreciate you. We can't say it enough. It really takes work for us to get up and actually find time to record in our both our hectic schedules. But if you're listening and you keep engaging with us and showing us that we're having an impact, and no better impact than what I told George when we walked in today by the quote that he got from one of the business meetings that I'm a part of, where one of the meeting members stood up and quoted patient zero in the actual meeting saying, hey, I listen to Byja Radio and this is a quote that everybody should know. It tells us that we're doing something right.
Right.
So if all that being said, we are still in your list of things to do and listen to, please share it with others. That's going to make it much more impactful. And eventually our hope is to get this to where it becomes something that helps more people engage in primary care, which is why we started this. So with that, George, I'll kick it over to you for the last few things. Where can the people find you?
You can find me on X, Elon Musk platform, formerly known as Twitter, at George_Becnel. Instagram is Becnel Media. Drop me a follow, say hello.
And a congratulations for sure.
Well, sure. I take that as well. Appreciate that. Yeah. And just if there's anything that you'd like to hear on the show, let us know.
Yep. And we will start by saying to get engaged with us at the clinic. You can check us out on our website, www.byja.org. We're also on LinkedIn and Facebook and Instagram at Byja Clinic, all one word. If you're engaging with us at the nonprofit website, it is www.byjaca.org, and that's for the Byja Charitable Alliance. I am Dr. Jasper, and we thank you so much for listening to us, and we will see you for our next episode when we see you.